Hello, everyone. My name is Brenda Lormil, and I serve as an oncology nurse practitioner at Massachusetts General Hospital Cancer Center. I also serve as the founder of the Haitian American Medical Association, where we provide culturally specific health education for the Haitian American community. My third hat that I love to wear is I do healthcare consulting through VDI Consulting, kind of really putting all of my hats together and supporting folks who have projects that improve healthcare diversity, access, and delivery in our communities. So I have the pleasure of doing these short segments to help folks understand various different disease processes. And I get to talk to some really cool people. And one of the people we're going to be talking to today, his name is Dr. Richard Lee. I get to work with Dr. Lee at MGH, but I'm going to let Dr. Lee tell you a little bit more about who he is and all the coolness he brings to life during the work that we do together at MGH. So, Rick, welcome.
Thank you, Brenda. It's my great pleasure to join you here today. My name is Rick Lee. Full name is Richard, but my name is Rick Lee, and I'm a medical oncologist at Mass General Hospital. I specialize in genitourinary cancers, so that's a focus on prostate, kidney, bladder, and testicular cancers. I do research in this area, and I take care of patients as well. I serve as the clinical director for the genitourinary cancers group at MGH, and I'm the Weissman Family Chair for genitourinary research. As part of the work that I do, I also work with Brenda in the MGH Cancer Center's Diversity and Equity Council. And so we have a shared vision of trying to improve access to care for all patients, but in particular, those who are underserved. So thank you for allowing me to join.
Thank you for joining, Rick. So, in your role, kidney, bladder, prostate, testicular, today we're going to focus our attention on prostate cancer. In the work that you do, I'm sure you already know that the disparities that exist in prostate cancer among men of color is very, very unfortunate. And that's why we want to focus our attention here today. The first question I want to ask you, Rick, is in your line of work, when you think about screening for prostate cancer, can you talk about the best forms of screening for prostate cancer?
Sure. So the most common screening test is the PSA blood test. So a PSA blood test looks for a protein that's made by the prostate cells. It's called PSA for prostate specific antigen. This protein is made by normal cells as well as cancer cells. So we consider a PSA to have a normal range, usually under 4. Because the cancers can make more of this protein, we try to identify cancers based on patients who have an elevated or rising PSA over time. So it's very, very important for men to start having screening at least by age 50, and then to monitor the PSA over time. The other additive to PSA testing is the rectal examination. So the only way that we can really feel the prostate is by doing a rectal examination. And while that can be something that no man necessarily enjoys, it can provide a lot of information about whether or not there's anything that feels suspicious about the prostate itself. Based on those screening tests, if there's a change in the exam or a concerning trend or change over time of the PSA, that patient would then be referred to a urologist and then perhaps have some other testing like an MRI, and then move on to having a biopsy. So I want to emphasize that just having a PSA test or just having an exam for the prostate doesn't mean you have prostate cancer. And it doesn't necessarily mean that all of the other things that can happen when you have a diagnosis of prostate cancer and management are going to come to pass, because these are things that men are frequently afraid of. It's that just being tested means they're going to have problems.
Mm. Very great point. And you talk about testing the PSA. Sometimes we hear that folks can be frustrated because they have an elevated PSA, right? But then the workup that they do doesn't really come out to be prostate cancer. So, can you talk a little bit about that?
Sure. When we look at statistics and patients who are getting a biopsy because the PSA is telling us that there may be cancer there, when we look at the patients who have a biopsy, we actually only find about 30% or so of patients actually have cancer at diagnosis or at biopsy, meaning that there's a substantial percentage of patients who don't have cancer with the biopsy. So that can be very reassuring that they don't have cancer, and yet we might not have a complete or clear explanation for why the PSA was a little bit elevated. In the sort of contemporary way that we identify this cancer, though, we are now using other tools that have really helped us find those patients who really need a biopsy and have increased the percentage then of patients who are being diagnosed with cancer who need a biopsy, but also increase the number of patients that we can just observe without a biopsy. So I'll just highlight that using an MRI test can also be very helpful, because in the recent, say, 10 to 15 years, the radiologists have done a very good job of focusing the MRIs to be able to identify prostate cancer problems. So if you're a man who has a PSA that might be something that we're concerned about, but the PSA is not, the MRI is not at all suspicious, this might not mean that you need a prostate biopsy. So we're learning as we go, but we're also refining our ability to find this cancer, and also fine-tuning the number of patients who actually need a biopsy.
Thank you, Rick. Just learning and listening to what you're saying, all I can gather is that it's very important to continue to communicate with your healthcare providers, and follow up is super important, um, because you guys are, every patient's case is specific to that patient, right? So some folks might go through with the biopsy, others might have an MRI. If biopsy results don't show anything, you still want to follow up with your providers. So lots of communication and follow up is very important.
That's absolutely true. And perhaps I can take this moment just to emphasize that it's really the screening and access to care that is the crux of how we can best manage the prostate cancers. In the U.S., what we know is that prostate cancer is the most common cancer of American men, and it's the number 2 cause of cancer-related death in the American men. Among Black Americans, as compared to the white Americans, Black Americans have higher rates of prostate cancer diagnosis and higher rates of death. But what we've learned is that when we're able to actually capture the patients early on in their care, meaning with screening and a biopsy and earlier treatment, that we can actually see that those disparate death rates, those differences in death rates and aggressive cancers, seem to go away. So having access to care and doing the appropriate screening is really, really important. And Brenda, you and I have talked before about the prostate cancer rates and death rates in Haiti, as we've covered before. In Haiti, prostate cancer is the number 1 cancer in Haitian men, and it is the number 1. I believe it's the number 1 cause of cancer death among Haitians in Haiti. So this is not something that's unique to the U.S., and I would just emphasize that this type of care, access, and screening is important for patients really globally.
Rick, I'm so glad you went into the statistics, because I wanted to start talking about that, and you beautifully laid it out, the information for us to understand and for our viewers to understand. Going taking like a more clinical route here. Um, we've talked before about uh, prostate, like an enlarged prostate, BPH, an enlarged prostate, and how sometimes men might have symptoms of an enlarged prostate, but be fearful to, reach out to their providers because they think it's prostate cancer. So, can you talk about the signs and symptoms of an enlarged prostate so that our viewers, whether male or female, if you're female, you could share with your loved ones who are males, and if you're males, just take it in for yourself, can know about?
Absolutely. So let's talk a little bit about anatomy and what is the prostate. So the prostate is a little gland that sits underneath the bladder. And the prostate's like a little donut. And it sits under the bladder, and through the donut hole goes the urine out of the bladder, through the penis, into the outside world. So when men get older, and we all get older, we'll all have our prostate enlarging over time. This is universal. This is no matter what country you're from. Your prostate enlarges. As the prostate enlarges, the donut hole can also shrink. So when the donut hole shrinks, that causes an obstruction to urinary outflow, meaning that it can be harder to get urine out of the bladder. So the symptoms of an enlarging prostate, not of cancer necessarily, but of an enlarging prostate, have to do with obstructive urinary symptoms. What are obstructive urinary symptoms? That might mean that their stream is slower. It might mean that you're waking up more at night to urinate. It might mean that you have trouble feeling like you're completely emptying your bladder, or at the end of urination, maybe you're dribbling. Maybe maybe the urine that you think you've completed, but there's still a little bit dripping out. Those are the symptoms of an obstructive prostate, and that's the donut hole issue. It does not necessarily mean you've got cancer. So that would be really important to distinguish, so that men understand, geez, I have urinary symptoms. That does not mean that I have cancer. It does mean, though, that you can get help. And the help doesn't necessarily mean that it's a prostate cancer problem. There are medications we give that can help with urinary flow.
Awesome. And then let's talk about pain, right? What if a man is experiencing pain in his prostate area, or, sits for a long time, has discomfort?
Yep. So I would say that pain, as it relates to prostate cancer, is actually a symptom of more advanced cancer. So if there's pain deep in the pelvis, that's a symptom that might relate to prostate cancer. That's not screening. Then this for a patient who's got, perhaps a bigger concern. If there's pain, though, just with urination, like burning pain with urination, that might be a symptom of prostatitis, inflammation of the prostate. That doesn't necessarily mean cancer. So when we talk about pain, if we talk about pain upon urination, burning pain with urination, that may be inflammation of the prostate, and that could be evaluated with tests of the urine and treated with antibiotics. If there's other pain deep in the pelvis, meaning deep, in your down in your abdomen, down in your pelvis, or pain in other places, that may be a symptom of more advanced cancers.
Awesome. Thank you so much for explaining that. Um, I'm going to go back to screening. So, right now, for screening, we talked about the PSA, we talked about the MRI, we talked about plus or minus a biopsy, depending on what the health care provider says. But before we go to any of those lengths, there's an age range, right? So, when should men start screening for prostate cancer, and is there a difference if there's a history of prostate cancer in their family?
Yeah, great questions. And this is something that evolves over time. For a period of time, there was a recommendation to not screen anyone for prostate cancer, and now we've sort of switched back towards saying that this is something that should be discussed between a patient and their doctor. Generally speaking, we recommend that PSA testing begins around age 50. If you're Black or if you have a family history of prostate cancer, we generally recommend starting even earlier at 45, and maybe even earlier if your family member is diagnosed at an even earlier age. So let's say a man is diagnosed with prostate cancer at the age of 52, and it's a significant prostate cancer, then his relatives should be screened 10 years earlier than the age of diagnosis. So if a man was diagnosed at 52, then we might be telling his family members to start doing screening at the age of 42 and having close follow-up over time.
Super important. I ask because a lot of times the medical history in families is not always shared openly. So, for those who are watching, our viewers, it is very important to know the medical history of your parents, aunts, uncles. I know it's sometimes a very sensitive conversation to have, if folks want to maintain their privacy, but it is also helpful for family members and generations to come to know how to best care for themselves and screen in an appropriate timing, just as Dr. Lee just mentioned. We are coming up to our time. But I know, yep, I know you
Can
have. Yeah, please jump in,
let me
please.
emphasize two things. You mentioned it earlier. For the women viewers, I will implore you, beg you, plead with you that you become a strong advocate for the men in your life, because I know that we as men don't actually see doctors very frequently, and it really is a family issue here of trying to get men into for access to care. And so I would say that if you're a female viewer here, please work with those men in your life. The second thing I'll just note is that there are many men who are diagnosed with prostate cancer. So let's jump forward to you've gone past screening, you've been tested, and you've been diagnosed with prostate cancer. There are many prostate cancers that grow very slowly over time. These low-grade prostate cancers may not even need to be treated. So the side effects that go along with treatment that everyone's concerned about may not actually come to pass because a man might not need treatment. So I think that's the other important piece here is that as we get better with trying to find the men who need a biopsy, we're also getting better at identifying the men who maybe don't need to be treated and where that cancer can be observed over time. And so we've learned that many men can be observed and the cancer does not actually cause any problem for them and doesn't shorten their lifespan. So even more reason why identifying the cancer is important, getting the screening is important, but not fearing that just getting the test means you're going to have problems down the road.
Thanks for explaining that. I know we're slowly running out of time, but I think it's really important to just touch upon the side effects of treatment, just so folks know. I know sometimes patients may say, "Oh, I never knew this was going to happen to me." But while we're here and we have Dr. Lee, tell us some side effects of treatment that men may face if they're actively being treated for prostate cancer.
Sure. So let's say if you have a cancer that's localized to the prostate, hasn't spread anyplace, the two major options are removal of the prostate or radiation therapy. That's if the cancer needs to be treated. Again, it's not all cancers need to be treated, so you might not need any of this stuff. Prostate removal means that it's an operation, and the side effects that go along with it might be leakage of urine or incontinence. That happens in a very low percentage of patients for when they're being managed by a surgeon who has a lot of experience. And there may be erectile dysfunction, meaning worse erections. We estimate that perhaps 75% of men are able to have erections after prostatectomy or even after radiation therapy with or without medications. And that very much depends upon the experience of the surgeon and whether or not he or she is able to spare the nerves that run alongside the prostate and help with erections. So the major issues with surgery are incontinence or urinary control and erectile dysfunction. Again, for a patient who's in otherwise good health and with a very experienced surgeon, these can be low percentage problems. For patients who get radiation therapy, the major side effects have to do with the fact that radiation to the prostate irritates the bladder because it sits underneath the bladder and irritates the rectum. So there may be more urinary symptoms or more bowel urgency, maybe a need to go to the bathroom more frequently during radiation that builds up and over time kind of quiets down. Over the long haul, there can still be erectile dysfunction, meaning issues with erections, about at the same rate, maybe a little bit better than patients who undergo surgery. But there's no incontinence, there's no issue with urinary control problems with radiation. It's just a different path to getting to cure. Surgery and radiation in general are considered equal in terms of their ability to cure this cancer.
Awesome. Thank you so much, Rick. Thank you. I'm sure our viewers have learned so much from the information that you shared. And I look forward to continue doing the work that we do together. And again, thank you so much.
It's my pleasure. Stay safe. Take care.